The following podcast is part of a certified educational activity titled Deploying the Immune Gambit Against Melanoma, Guidance on Advances and Medical Breakthroughs with ImmunoTherapy. Access the entire activity and complete the post-test at peerview.com/BYP860. Downloadable slides and practice aids are also available.
Hello and welcome to this PeerView program titled Deploying the Immune Gambit Against Melanoma. It is too clever of an acronym. I will let you read it. My name is Hussein Taubi. I'm a professor and deputy chair of melanoma medical oncology at MD Anderson Cancer Center, and I'm really excited here to have my good friend and colleague, Professor Christian Blank, who is the head of molecular oncology and immunology at the Netherlands Cancer Institute and a leader in the field of melanoma. So starting with metastatic melanoma, I think we're really excited in this field that in the last 10, 12 years, we have made tremendous impact on our patients with melanoma. And this particular slide really summarizes this evolution. You see the ipilimumab, which was in 2010, the first plenary session for melanoma at the ASCO annual meeting, and it was the first time we saw a survival benefit. And I consider this remarkable that now it is the worst survival curve you see here, because we have made such amazing improvements with both the BRAF and MEK inhibitors, single agent PD-1, and then the combination of PD-1 and CTLA-4, and our median survival now exceeds 5 and is closer to 6 years, which is really remarkable. And since 2021, there's been a lot of other developments, and I think this is where we're here today to discuss some of them. First, we have newer targets like LAG-3 and the approval of the combination of PD-1 and LAG-3 in metastatic unresectable disease. Very recently, we have now TIL approved in the PD-1 refractory setting or post-ICI setting. PD-1 inhibitors have kind of made it all the way to some of the earliest stages of melanoma, including stage 2. And very importantly, we now have neoadjuvant therapy that's emerging for patients with resectable disease. I will even correct myself. It is not emerging. It's proven now as of Sunday, as you will hear from Dr. Blank, for single agent and both combination therapies. So today, what we're going to be trying to do together here is to improve the knowledge that you have of the updated guidelines and some of the evidence that led to those updated guidelines and how to integrate them into your management protocols. We will help you think through ways that you could personalize treatment for your patients with metastatic unresectable melanoma, but also patients with resectable melanoma who could be considered for neoadjuvant therapy or potentially adjuvant therapy. And along the way, we'll provide you with some guidance on managing practical aspects of immune-based therapy for melanoma. So here are my very long titles that I will not go through, but I'm going to address first the right move in advanced melanoma, established and emerging immune agents and combinations. And I'll start with a case and actually kind of maybe put Dr. Blank on the spot here. So we have a 78-year-old patient presenting with metastatic disease to the lungs, really common presentation. Brain MRI is negative, LDH is normal, the patient has a performance status of 1, and wild type for BRAF. So when you see a patient like this, Professor Blank, what do you think, and do you consider that because of the age and the profile that this patient is, I don't know, too old for combination immunotherapy?
No, this I don't think. Patients, we have treated, for example, also in a neoadjuvant situation, patients up to 85 with neoadjuvant ipi-nivo. For me, the argument against in this patient giving combination would be the normal LDH level. And solely several lung lesions. So the patient has no high tumor burden, has no liver mets, and no elevated LDH and no brain mets. These are the parameters for us normally to argue for a combination therapy. So in that way, patients could start with either PD-1 blockade or PD-1 LAG-3 that are equally very well tolerated. Yeah.
Would you consider any sort of local therapy? And, we know that sometimes for lung cancer, SBRT and other approaches have been considered.
Yeah, so there are multiple lesions, so I would go for systemic therapy. But for example, if after regression of all lesions, suddenly only one lesion pops up, this I would undergo local therapy, and then in this patient, preferentially a local irradiation. Yeah.
And Christian, you've actually presented with the neoadjuvant data some quality of life tools. Do you have any specific tools you use for geriatric patients when you're thinking about the first line therapy?
So if we are in doubt, then a geriatric will see the patients in our hospital. But you can also ask the patients what they are doing, if they can manage their life completely themselves. Then a patient is eligible for systemic therapy. Yeah, the patients I speak that had chemotherapy and switched then to an immunotherapy always say what a relief immunotherapy is. Yeah, so I think we over exaggerate the immune-related adverse events often in the field. Yeah.
And then I'll be going over the long-term data from PD-1 LAG-3, which I think is very important for thinking about this patient as well. And so, the evidence really kind of supports the use of combination. And to Christian's point, PD-1 LAG-3 is an effective combination for this particular population. I think the idea of thinking about the toxicity is very important, not just to make sure that you explain that to the patient and you prepare them. But really, I think importantly for elderly patients specifically, I find that asking about the social support that they have is very important because, some immune-related adverse events that may not be your grade 3 and 4 toxicities that you need to admit them to a hospital for may still be debilitating for a population that is kind of, again, in the elderly space. And I think really important to think about those things. We are providing you here some of the kind of tools and some of the resources available to support your patients through this. And I think AIM-at Melanoma is probably one of the most kind of advanced and well-curated websites that has worked closely with experts like myself and Dr. Blanc to develop these guidelines and resources for you and your patients. So I really highly recommend you consider this website to get the information you need to educate your patients and their families about immunotherapy toxicity. So looking at the data that was presented, first of all, the NCCN guidelines have now been formally amended to have a very specific recommendation with 2 combination regimens that are preferred. So Nivo-Ipi, both based on Checkmate 067 and the DREAM-seq trial that we now know you have to start with combination immunotherapy up front, and nivolumab and relatlimab based on the Relativity trial. Both are category 1. Now note that all of the other combinations, single agent PD-1 or combination BRAF and MEK, also are category 1 evidence, but they're no longer under the preferred rubric, again, because we're going to discuss some of the data that shows that this is more, that the combinations are more efficacious. And then we still have targeted therapy, obviously, for BRAF mutated melanoma, and there are patients that may be best treated in that way. And then the pembrolizumab and low-dose ipilimumab is a category 2B. So let's go over Relativity 047 data. I just presented this past Saturday at ASCO the 3-year update on the study, randomized phase 2-3 trial. It had 714 patients, and the primary endpoint was PFS. That's what the study was primarily powered for, PFS by blinded independent review. And what you see here is this early and consistent benefit for the combination over single agent PD-1. Now 3 years and almost 4 years out with a hazard ratio of 0.79, highly statistically significant, the median PFS of 10.2 months versus 4.6 months. Importantly, we are interested in the different subgroups and kind of what the impact on those particular patient populations are. And since we presented an elderly gentleman, I'm actually showing you here that, the benefit persists no matter the age. And I think for efficacy perspective, you actually do have at least a 10% improvement in objective response rates across the board, sometimes a little higher, sometimes a little lower, but about 10%. And so I think both based on PFS and objective response rate, there is no reason to hold off treating with combination from an efficacy standpoint. And, again, whether BRAF mutant or wild type melanoma, the difference is, again, about 10%. Now, to Christian's point, high LDH patients just honestly do poorly no matter what you do. So we try combination immunotherapy with them. You see that PFS still shows improvement. The response rates are more limited, and you see a lot of excellent responses for LDH normal. Now, I also bring up in the discussion, Christian, you said, well, maybe we should do single agent if the LDH is normal, but look at that 15% improvement in objective response. So I would argue even with normal LDH patients, we have a lot of efficacy to tap into with nivo-rela. Now, most importantly, this is what we presented this past week, is that now we have a long-term follow-up, and we've learned that with checkpoint inhibitors, really the tail at the end of the curve is what matters the most, and the long-term follow-up is what teaches us about different combinations. And now we have a sustained improvement in overall survival. It happens from the start of this curve and goes all the way now to 4, 5, and 6 years out, and we see a hazard ratio of 0.8, a 20% sustained improvement. You see the confidence interval does not cross 1 anymore. We have to be careful that this is an exploratory analysis, so technically we cannot call this statistically significant, but it definitely looks like an absolute benefit for the combination over the single agent for survival as well. And then when we think about overall survival, I always wonder, are the patients dying because of other causes? The median age typically is about 60, 65. And here's the melanoma-specific survival showing a consistent improvement, and again, a hazard ratio of 0.75 for melanoma-specific survival. So I think this is really, really important. What we saw at the meeting as well is triplet therapy. And with triplet therapy, this is a very early study. It was 46 patients. It was a phase 1B, so to speak. So it was a more safety-directed study that Paula Ascierto presented. And this is the first time that we're adding the three checkpoints together. So nivolumab and relatlimab at their usual dose every 4 weeks, 480 and 160. But the innovation here is adding ipilimumab at 1 milligram per kilogram, but note Q8 weeks. So this is an interesting regimen. The toxicity is most relevant here, was only 39%. And I say only because we know the high dose ipi-nivo is closer to 59%. And now the objective response is high in the 59% range by investigator and 52% by blinded independent review. So we're seeing kind of an evolution of the field with the checkpoints. And importantly, Relativity 127 is also studying a different administration of nivolumab and relatlimab that could be sub-Q, and this may become commercially available relatively soon, which kind of will really help the kind of the administration of this combination. I still have a couple of slides in the post-PD-1 setting, but I think maybe a good time to address the questions in the chat. For acral and mucosal melanoma, we see that the combination of nivolumab and relatlimab has about a 30% response, which is equivalent or what you would expect from ipi-nivo as a combination. And then for patients and age, I really do not consider age a reason to treat or not to treat. I really think more about it in the context of, are those patients going to be prepared to handle some of the toxicity? And very, very rarely do I ever do single agent PD-1, even in older individuals. I have used it in patients that were kind of in their upper 80s, if I'm using it as a neoadjuvant therapy with 1 or 2 doses. And maybe we'll get to that when Christian and I talk about the neoadjuvant component. I personally feel that and that's the question that was also posed. I personally feel that the role of single agent PD-1 in first-line metastatic disease is over. It is a regimen that we only use in very, very unique situations, but combination nivo-rela with 22% grade 3/4 toxicity really puts you in a very good place, and it's a combination that is relatively easy to manage. Christian, any comments on those things before I present the post-PD-1 data and then turn it over to you?
Yeah, I agree fully with you. From my perspective, I have to admit that in the Netherlands and in many countries in Europe, Nivorela is not yet approved and compensated. Therefore, when I think in doublet versus monotherapy, it's Ipi-Nivo versus Nivo. If one wants to go definitely for monotherapy versus Nivorela, yeah, then you need the PD-L1 staining, because you could argue that somebody who has a higher PD-L1 staining, that could be equally benefit from anti-PD-1, but for all others, it's in what the study has shown, Nivorela together.
Yeah, really interesting points. And again, in Europe, the PD-L1 status is a requirement. Despite that, I never check it in my clinic, and I treat my patients up front. I can tell you that speaking to many of my colleagues at this particular ASCO, it was remarkable to see how many of them are kind of becoming more accustomed to using the combination, and it's in the US we can use it with no issues. It's already in the NCCN guidelines. Thank you, Christian. I will move on to one presentation.
Hey, there was one question. Would you ever consider adding a BRAF/MEK to an immunotherapy in case you are seeing a sluggish response upfront immunotherapy in metastatic melanoma?
Yeah, so go ahead, Christian. You want to address that?
Yeah, we have published the Impembra trial where we gave intermittent BRAF/MEK to anti-PD-1, and it's a small phase 2 trial, but we see tremendous outcome without too much toxicity. The trick is that you shouldn't give it in parallel, but just intermittent, 1 or 2 weeks in between the infusions, and then this works. And I do this often when I have patients that have very high tumor burden, and you have the feeling that you will not get them through the immunotherapy. Then I add the target therapy, but intermittent to the immunotherapy. I don't know how you do this.
Yeah, I mean, specifically now we have 2 randomized studies from Europe, from Paolo Ascierto's group in Italy, with the 8 weeks of Incobini ahead of switching to Ipi-Nivo, and the data that Caroline Robert just presented at ASCO as well, the EBIN trial, where you do 12 weeks of Incobini and switch. And that seems to be a more reasonable approach. So in very select cases, you may want to consider kind of a short course of targeted therapy and switching as quickly as you can to immunotherapy, because that's where the long-term benefit lies. So in the second line, obviously the first layer here of NCCN guidelines is whatever you didn't use in the first line, you could consider using in the second line. So if you didn't use combinations, obviously you can do combinations. If you did one combination, you can switch to the other for immunotherapy. Obviously for BRAF mutated melanoma, you can always use a targeted therapy in the second line. And now we have lifileucel, which is really a remarkable development. And it's for patients with PD-1 refractory disease. You have a response rate of 30-40%, and it's a one-time deal, which is really important. I did want to present a really cool molecule that we've seen already make an impact, or at least the platform make an impact in uveal melanoma with the bentafus. We saw data from the same kind of idea, which is this bispecific antibody that brings an unsuspecting T cell that had CD3 positive, brings it closer to an antigen presenting cell that has PRAME being presented. And so the bispecific has PRAME on one end and the CD3 positive receptor on the other end. And it really allows for T cells to recognize these tumors and kill them. And, we're really excited because this showed a 13% response in a very refractory population. But most importantly for this platform, we see that patients that stand in a stable disease situation, they actually are patients that may still benefit. And we see the PFS and the OS actually being reflective more of benefit in that population than just the pure tumor shrinkage. So really exciting platform, and something that will potentially become a powerful resource and a powerful tool for us. We are waiting to see the phase 3 trial for this in the first line setting has just been initiating. So in the next year or two, we may find this in our clinic as well as a potential treatment approach. So with that, I will turn it to Professor Blanc that I presented earlier. Again, really made a tremendous impact this past weekend. It's the third time in the history of melanoma that we're on the plenary session, and Dr. Blanc did a phenomenal presentation there. So I'll pass it on to you to talk to us about neoadjuvant therapy, Christian.
Thank you very much for the nice words, and I welcome the audience. Just returned from ESCO. And I also want to start with a case. It's a patient with a stage 3C melanoma, 6 millimeter depth, 5 mitosis, no ulceration, 3 PET palpable inguinal lymph nodes, beer of mutated melanoma, no significant past medical history. So, and this patient, Susan, is 56-year old. So, Dr. Tavi, what would you do?
Well, I mean, in the past, we used to run to surgery because we felt that surgery was the only curative option we had in metastatic melanoma and then, or in stage 3 melanoma. And then we were happy to see that we can now use adjuvant PD-1 or in some cases BRAF/MEK to decrease the risk of recurrence. Mind you, the risk of recurrence for a patient like this is as high as 60 or even 70% if you do surgery alone. So we were very happy to have adjuvant therapy available to us. And then we started seeing the preclinical rationale and then the clinical rationale to use these drugs early before we do surgery, which was the neoadjuvant approach. And it transformed what we do. The benefit far exceeds what we expect from surgery and adjuvant, as you will see soon. So at MD Anderson, I can tell you my surgeons yell at me if I don't consider neoadjuvant therapy. So
Very good. Okay, I see you attended well the ESCO meeting. So now the next slide is for the discussion, is the patient a candidate for neoadjuvant therapy? We discussed already definitively. If so, immunotherapy or BRAF/MEK. I think we had a great statement from Georgina, based also on the data from MD Anderson. Both are options, but the intention is different. If you give BRAF/MEK inhibition, you want to have a fast reduction of size to make something operable, but the stability and the relapse-free survival is not the same quality like what you achieve when you have a deep responder from immunotherapy, where you have this flat line relapse-free survival, while after BRAF/MEK it drops. So in most cases, you want to try to give the patients immunotherapy. And then the question next, single agent or combination. I think it's a flavor. I prefer the combination because I show you the data at once based on NADINA. You are in 60% of the patients done after 6 weeks of therapy. These patients have most likely also a higher EFS than the monotherapy with anti-PD-1 neoadjuvant. But this comes at the cost of, and what for me most important is a 7% endocrinopathy adrenal insufficiency as compared to a 1.2%. So this is something what you definitively have to discuss with the patient. And I'm highly convinced that subsequent adjuvant therapy is not needed in patients achieving a major pathologic response. What to do if you don't achieve a major pathologic response? I was convinced that the class switch to a BRAF/MEK inhibitor would be the best. But from pooled analysis from Irene Reyes and from ESCO 2023, we saw that patients that were non-responder and had received adjuvant therapy, initially the BRAF/MEK treated patients have done better, but then like in stage 4 disease, the crossing of the curve came. At the end, the distance metastasis-free survival difference was above 20%. Yeah, so in that way, I switched my mind a little bit towards a tendency also to continue the immunotherapy also in BRAF mutated and non-responders. I don't know what your thoughts are.
Yeah, so I think first of all, trying to induce the highest potential immune-based response is your goal in the neoadjuvant setting. So, I consider single agent to be inferior to combination. So I usually go for combination. A question in the chat is, what is a pathologic response you're looking for? It's called major pathologic response. You'll hear it from Christian. And it's basically less than 10% viable tumor is what you're hoping for. And Christian has convinced me not to use adjuvant therapy once it's a major PR, once it's a major pathologic response. Once it's a lower response, then potentially switching to BRAF/MEK makes a lot of sense.
Yeah. Okay, and then we have another question. Enthusiasm taking the Prado approach, potential limiting the therapeutic lymph node dissection. I'm totally convinced of that. In NADINA, we have not included this. I come to this because it should be a trial that could be registered at the end. But nowadays, if you give neoadjuvant ipi-nivo, remove one lymph node, see a near CR or PCR, then you don't have to go for the therapeutic lymph node dissection. You might have a slightly higher percentage of local relapses, but we saw the distance metastasis-free survival identically compared to the patients that had undergone the therapeutic lymph node dissection. And this is really giving a lot of morbidity, for example, when you do this in the neck region. So Susan had a candidate for neoadjuvant therapy. We discussed this already. Subsequent adjuvant options we have already discussed. We prefer in major pathological response rate less than 10% vital tumor in the resection specimen not to proceed with an adjuvant therapy if this is not this excellent outcome. At the data that we at the moment have in the BRAF mutated status, we would, based on NADINA, advise with adjuvant BRAF/MEK, and in the wild type status adjuvant PD-1. But based on the pooled analysis, you could also consider to continue anti-PD-1 in the BRAF mutated status. And now we come to NADINA, and this is the first trial where we have the support of a potential 6 weeks course. And this I want to show you with great pride. Here you see first the rationale for neoadjuvant immunotherapy. I want to go quick with you through that. In former times, we removed our lymph nodes and then started the adjuvant immunotherapy. And then our immune system had to be activated by micrometastasis. And this is what we know doing not strongly. And we have shown in our peasant trial that indeed in the periphery, you see hardly an expansion of the tumor-resistant T cell clones. While if you start your checkpoint inhibition upfront, then you have the full danger signal from the tumor and also the whole variety of the tumor neoantigens, also a certain good load of tumor neoantigens, and then you have a strong immune response. And this you find in the peripheral and patrolling way more T cells that can recognize the micrometastasis. And this has been shown in very well-defined animal models, but also in randomized early phase trials. So there is no discussion that neoadjuvant gives a stronger and broader immune response. Yeah. So in that way, the immunotherapy has a big neoadjuvant immunotherapy have a big advantage against all other approaches in neoadjuvant chemotherapy or radiotherapy, that aside the tumor reduction, it gives really a stronger immune response that prevents the relapses. The NCCN guidelines supported by SWOG 1801, neoadjuvant pembrolizumab, and now until now supported by OPECI-NEO and PRADO, which were smaller phase 2 trials than the SWOG 1801, a neoadjuvant ipi-nivo plus ipi. We had also a very nice trial from Hussein Tabi where they combined the nivo plus RELA. unfortunately have gone in the adjuvant part fully also with nivo-rela and therefore had more toxicity than ipi-nivo. But I believe when you look at the 12 weeks data, this is a very interesting combination because it was hardly toxic and had pretty similar major pathologic response rates than ipi-nivo. I talked about it already, BRAF/MEK neoadjuvant. I would only use if my surgeon hangs me in the neck and says, you have to reduce this, otherwise I can't operate the patient, because the long-term benefit will be definitively lower for this combination compared to the immunotherapies with their flatline EFS curves from both. If you achieve a deep response with anti-PD-1 or with the combinations, you have a flatline after the surgery. Here you see the from Nadina, the study design, and the inclusion criteria were slightly different from Opacin, Neo, and Prado because we aside the macroscopic melanoma metastasis to the lymph node, we allowed also patients to have in-transit metastasis. And these patients needn't to be RECIST measurable, so it could be also a palpable lymph node that was biopsied or by echo control found. So it was a broader inclusion criteria to allow the whole spectrum of patients that occur to be included into this trial. And the neoadjuvant experimental arm consisted of two courses, flat dose ipi 80 milligram, nivo 240 milligram, 3 weekly given, then therapeutic lymph node dissection. And we discussed it already. If the patients achieved a major pathologic response, meaning less than 10% vital tumor cells in the resection specimen from the therapeutic lymph node dissection, no adjuvant therapy was given, and right away the start of was. And these are 60% of the patients, I would like to admit. The majority in this trial was done with 6 weeks of treatment. If you didn't achieve this deep response for the patients, then the patients received either 11 courses of nivo for 80 Q4 weeks for the wild-type patients or 46 weeks Daptram for the mutated patients. You see this is a little bit shorter than the adjuvant, but we wanted to ensure that the patients had, with the neoadjuvant plus adjuvant, the same amount of therapy than the control arm, namely upfront therapeutic lymph node dissection followed by 1 year nivo adjuvant. What are the results? I think the results are spectacular, but I'm also subjective because I presented the data. But I think a trial showing to a hazard ratio of 0.32 against an active comparator, which is also the most modern comparator at the moment, the standard of care at the moment, is hardly seen in the field. With a p-value of 0.0001, we saw that in the neoadjuvant arm, an estimated event-free survival of 83.7% was seen, and in the adjuvant arm of 57.2%. I remind you again, this 83.7% were achieved with 60% of patients receiving only 6 weeks of treatment. When we look into the BRAF mutated status, then you see both patient groups benefit, the wild type and the mutated, with hazard ratios of 0.35 and 0.29. So in that way, it's over that you have to think of what should I give as neoadjuvant therapy according to the BRAF status. Both groups benefit very well from this neoadjuvant combination. When we look now into the major pathologic response, and that was a little bit of trouble from SWOG 1801, that the central vision was a little bit incongruent with the local assessment. This was not the case with Nadina. You see clearly that the local assessment on basis the adjuvant therapy was given or not given is no discongruency to the central review. We have reviewed all patients. The gray not reported yet are the patients that had not undergone surgery or were still on treatment, because the data cut was after the last patient was included. Similar to previous trial, we saw a major pathologic response rate of 59%, so exactly in line with what we've seen previously. And nicely that I can use my cursor now in contrast to the ESCO meeting, because then I can explain this slide here on the right side to you. Here we compare the radiologic versus the pathologic response. And you see patients that have a radiologic CR, almost all patients have also a major pathologic response as resembled by the green color. Partial response the same. But it's striking, if we achieve a stable disease according to the radiological parameters, then still more than half of the patients achieve a deep response. And this undermines, for me, the need to analyze pathologically the result from the neoadjuvant therapy, because especially in the stable disease patients, you otherwise overtreat your patients if you give everybody adjuvant therapy. For the progressive disease, it's pretty consistent now, radiological and pathological response. If you look now at the adverse events, then in both arms we had more than 90%. Any AE, grade 3 of higher toxicities were in 47 versus 34% in the neoadjuvant higher. And this splits into surgery grade 3 or higher related adverse events of 14% in both arms, which is a really nice result, because we were often frightened of that the neoadjuvant immunotherapy impairs the easiness of the surgery and would increase the surgery-related adverse events, which is absolutely not the case. And the others, from this 47 minus 14, you get the 30% systemic grade 3 or 4 toxicities as compared to 14% for the adjuvant here. So you can, rule of thumb, say you have twice the grade 3 toxicities in the neoadjuvant arm. But because it's shorter and people think of it's maybe even safer, because what you see, unfortunately, only in the adjuvant arm we had one death due to immune-related pneumonitis. And that could be because if you treat very long and you think it's super safe, then people sometimes forget to react to adverse events. While if something is only in 6 weeks treated, then the physician really concentrates on the adverse events on the patient. And therefore, we had no death in the neoadjuvant treatment arm. So the take-home messages from Nadina was that Nadina is the first neoadjuvant checkpoint inhibitor in melanoma. So with that, we have now established, really based on a phase 3 trial, neoadjuvant therapy, after we had already very nice elegant phase 2 data from the SWOG 1801 trial. This is also the first trial that combined only immunotherapy. We have seen in other malignancies at the moment only add-on neoadjuvant therapies, the chemotherapy, and then immunotherapy was added. And this is now the first trial where really pure immunotherapy was used. The hazard ratio I have shown you, and I would like to remind you that this fantastic data we achieved with 60% of patients being treated only for 6 weeks. This is not only time-wise or stress-wise for the patients of a great advantage, but it's also financially interesting. That the patients in areas where they have to pay themselves, that this is a less expensive treatment, and it's also a treatment that needs less hands, from the healthcare professionals. In the next 20 to 30 years, we need to treat twice the oncology patients with the same hands, and in that way, we have to think intelligently about schemes that save also the hands of our healthcare professionals. And as not shown here, but shown in the ESCO presentation, all subgroups benefited. I showed you only the BRAF mutated and BRAF wild type status. So what will be the future and the next steps? I think the pathologic response is still the gold standard to decide whether you want to give adjuvant therapy or not. But there are now new novel parameters that will help us also. And one was the PET-CT. When the PET-CT becomes less than 70% the SUV, then in the lesion that was positive, then it seems to be also correlating with the major pathological response. And here you see also a very interesting analysis where they have looked into patients that were ctDNA positive and became negative, or where they were negative and became positive. And this correlated really nicely with response of relapse. The problem is that only about half of the BRAF mutated patients we currently can detect the circulating tumor DNA. So if we can detect it, then it's a very good surrogate marker for us, a good help. But it is not something that you can use in all patients. That's the challenge. It must become a little bit more sensitive, but it's a really nice paper showing where we should go. Another very interesting presentation we have seen also from Axel Hauschild at ASCO, namely immunocytokine therapy, and that is Darumune, and that is an IL-2 bound to fibronectin and an TNF bound to fibromune, and they are injected locally. And with this fibronectin, it is thought that these cytokines are kept in the tumor area here. And it was a really simple trial, very interesting, randomized, then 4 weeks of injections into the tumor and then surgery, and that was compared to surgery alone. And this is the outcome of the patients. You see clearly that the pre-treatment with the cytokines gives a better outcome than the surgery alone. And also for the distance metastasis-free survival. I have to say that 30% of the patient had been pre-treated with anti-PD-1 up front, but there was in the hazard ratio no difference for that. So, Dr. Tabi, what do you think when you see our neoadjuvant checkpoint inhibitor therapies from pembrolizumab or from Ipi plus Nivo and in this one? So where will we position this in the future?
Yes, thank you. So I think, first of all, I think, again, congratulations for Nadina, absolutely practice changing. And I think, combination immunotherapy with Ipi-Nivo, and thank you for the shout out for Nivo-Rela, I think maybe considered. But after that, I think this approach is really, really interesting, both, scientifically and clinically. And again, to your point, the trial is being ran, I think, a phase 3 now in PD-1 refractory disease. So as we know, with adjuvant therapy, we don't cure all the patients. We decrease the risk by half, but almost 40% still recur. And I think that's a population that would really benefit from such approaches. So we're really excited to see that. We're happy to answer a couple of questions in the next 2 to 3 minutes. So now that there are multiple neoadjuvant trials, how do we decide between the combinations and single agents, and does the degree of nodal involvement make a difference? Christian?
Yeah, for me, Ipi-Nivo is the standard nowadays. It's a phase 3 trial that shows the best hazard ratio, the best event-free survival. I think in the future, we will work on defining subgroups that can benefit from anti-PD-1 alone only. We have so far no adjuvant therapies as neoadjuvant schemes where we have stopped after a good response the adjuvant therapy for the monotherapy. So in that way, we have the personalization at the moment only for Ipi-Nivo, and in that way, that is for me the standard.
Yeah, so go ahead, Christian.
Yeah, and so I think for now, doublet is the standard. Ipi-Nivo is the standard. I'm looking forward to see more data from Nivo-Rela, and looking forward also to see data from for example, signature-driven, interferon signature-driven decision, doublet versus monotherapy in interferon signature high patients, for example. Yeah, there I expect that the anti-PD-1 could be also equally good. We have
Yeah,
5
so Christian,
minutes
if you
of
can
the
go
last.
through the adjuvant slides real quick. Yeah.
Yeah. So, and then for sure, we have talked only about stage 3 at the moment, and we have for sure also now an interesting options for the stage 2 therapy. Based on that, it was until now the white excision. If it was for the primary treatment, then we do the sentinel node analysis. If the sentinel node is positive, then it was stage 3 workup, what we had discussed. But if the sentinel node is negative, but we have now a high-risk stage 2 melanoma, then we have, meanwhile, based on phase 3 trials, also novel options, namely pembrolizumab and nivolumab anti-PD-1. And we have tumor site radiation, but this has only a control for the local site, but was in some studies even at worst for the overall survival. So for me, this category 2B is out, and we have for the 2B and 2C only pembro or nivo as options for stage 2. The guideline continues, and you see this is now we switch to 3 nivolumab anti-PD-1 in the adjuvant setting and dabrafenib. However, what we've seen now at ASCO this year, dabrafenib from the Combi-AD long-term data was only a numerical OS benefit and no statistically significant benefit. So if you want to be sure as a physician that you advise a patient an adjuvant therapy that is statistically significant, proven, giving an OS benefit, then you should not consider the BRAF/MEK inhibition anymore in the adjuvant setting. So, and was something novel, and that is much more interesting, is the INT, the individualized neoadjuvant neoantigen therapy in combination with PD-1. So we spoke already during the neoadjuvant session about the tumor neoantigens, and by sequencing the tumors, we can meanwhile predict what kind of neoantigens the tumor can present in the HLA. And this is done by an algorithm, in silico algorithm. So you take the tumor sample, you sequence it, you make the in silico prediction, and then you produce a vaccine, an mRNA vaccine with up to 34 neoantigens, and then you can give this to the patient. And we have seen very nice update from the data presented by Jeff Weber from the Keynote 942 trial. And this is adjuvant pembrolizumab against pembrolizumab plus this personalized vaccine. And what you clearly see that beyond 6 months, you see an discrimination of the curves with a 30-month recurrence-free survival of 55.6% for adjuvant anti-PD-1 only versus 74.8% for the vaccine. And this is pretty similar to neoadjuvant anti-PD-1 difference when you look at the SWOG trial, and I discussed this with Omid Hamid already. Maybe this neoantigen vaccination simulates neoadjuvant therapy, thus the full presence of the neoantigens, and gives them supports the PD-1 blockade in that way that it comes in much better out. So this is a very interesting approach. I'm very curious if MSD and Moderna manage it to make it as fast as possible, and maybe even to incorporate this into a neoadjuvant project, because that would blast, I think, in the future. So very interesting data. And I'm very happy that after a little bit time of stillstand where we only focus on checkpoints, we see now really novel, cool therapies coming to the market. The immune-related adverse events were exactly the same. Wouldn't be surprised if that would be different because you vaccine with something which is in the patient. So it's nothing that you make a novel cross-reactivity, but you just vaccinate with the neoantigens. So you more support the broadness of the immune response than with the novelty. It could be different if you combine this with CTLA-4 blockade, I think. Yeah. So
Excellent.
then we are at the final, and we have hopefully some minutes for questions at the end.
Yeah, we have a couple of questions. So one question is about the use of PD-1 in the US versus the EU. I can tell you in stage 2B and C, we do use it in the US for 2B and C regularly. I present it to all patients. There are situations where patients may choose not to. I don't push it as hard as a stage 3 patient because the absolute risk reduction is more limited, and you have to take it in the context of the toxicity, which could be long-lasting. A lot of patients do choose to be treated, and some patients do choose not to be treated, and I think that's kind of how it normally is. How is it in Europe?
So in Europe, most countries don't have it yet, or some even rejected it. That was Sweden. Because the strong focus, and that's the difference between the US and Europe, is that adjuvant should improve overall survival. And seeing this not coming from the adjuvant in stage 3, it is even higher unlikely to come in stage 2 because the absolute differences are smaller. So I think the adjuvant anti-PD-1s will have it hard in Europe. But we are working on neoadjuvant already, and MIA Australia also. And I think this will be only a transient difference. And at the end, we will come together all on neoadjuvant approaches.
What did you think of Paulo's trial of BRAF/MEK and immunotherapy in the neoadjuvant phase? Because that's a
Very
question
nice.
that's being asked.
I can tell you we are trying to lobby already since years together with Georgina that we for example, in unfavorable patients want to test the triple therapy. And with this toxicity profile that we've seen, I'm definitively not worried to try it. So I think we should try this, yeah.
Yeah, I mean, my perspective is that, the PCR that you get, as you heard from Christian, with targeted therapy does not have the same long-term impact. There are patients that you may want to do the 3 drugs together. The data from Paulo's study is interesting, but it's much more a very small study. So until we have a bigger phase 2 that's randomized or a phase 3 trial, IPI and Nivo would still be kind of the standard, with some consideration, hopefully, as data is being generated for PD-1 LAG-3 as well. Christian, so good to see you. Glad you made it home safe.
Yeah, thank you very much. Bye-bye.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported through an educational grant from Bristol Myers Squibb.